All right, Brian Cunningham here with Dr. Kevin Bozic, now at UT Dell, formerly UCSF, one of the real thought leaders in joint replacement, medical policy, kind of the transformation of healthcare. So we're here to ask him a couple questions following one of the sessions at the annual AUKUS meeting. I think one of the hot topics was transition in healthcare. What are kind of the baseline thoughts for someone who hasn't ever really tried to collect patient-reported outcomes?
Yeah, so it's interesting that we're in a business where the primary outcome that we care about and our patient care about are pain and functional status, and yet a very small percentage of orthopedic practices actually measure pain and functional status in any validated way. I think most of us think that we do that intuitively through our conversations with our patients, through our history, but when we actually measure physical health, emotional health, functional status, pain, it's often very, very surprising in terms of how our patients really feel about their condition and the care that they're trying to receive. I think that the most important step in understanding how that data is important is actually using it in clinical practice. If it's measured as another thing that we're measuring that's an extra burden for patients or providers, it's rarely used and the compliance is extremely low.
Sure.
And so we had experience in California with starting the California Joint Replacement Registry. We had variation from 0% to 98% of patients that were reporting this information depending on the practice, and we found out that the practices that were doing it at a higher level were actually incorporating into their decision making. So in my practice, I collect that information, I sit down with the patient, I show it to them and say, this is what you're telling me about your health, about your physical health, and about your emotional health. And based on that information, here's some options that we might try. I'm always surprised that patients say to me, where did you get that information? And I say, well, I got it from you. This is that stupid survey you filled out when you came in that you were angry at us about. And so I think that the key is actually using that information in clinical decision making for both patients and providers, and there's very few places that are doing that or doing it well, and until that information is started to be used in clinical practice, I think we'll continue to see relatively low compliance with collecting that information.
As far as practices getting up and running, trying to collect this information I think has been a challenge nationally, regionally, within practices. Do you think, and I know you've published on this topic, whether it's electronic, whether it's in office, different ways to do it, do you have advice on kind of an infrastructure or a way to go about it if you're a practice that's trying to transition towards collecting patient-reported outcomes?
Yeah, I think this is something we've looked at a lot within the AEOS, and we've actually recently started an initiative within the AEOS to, number one, streamline which measures that should be collected for which types of conditions and practices so that we have common benchmarks, because if I'm collecting one thing and you're collecting something else, it's hard for me to understand how I compare or how my patients compare. The other is baking it into the workflow is the simplest way to put it. So again, if it's seen as an extra, this goes back to my last answer, if this is seen as something extra that's not necessary to deliver care, like if patients believe that checking their range of motion and watching them walk they can understand why that is critical for me to be able to, or getting an x-ray. Looking at an x-ray, none of us would think about walking into the room and treating a patient for arthritis without having an x-ray to look at. Unless it's seen as critical, for just as critical as the x-ray, it's unlike, so it has to be built in, just like you're now going to x-ray, you're now going to get this survey that you fill out, and you can certainly do that electronically, although we found that even with the best and the most sophisticated and army of people hounding them, you might get to 50% of patients that you can get that information from ahead of time. Otherwise, we do it in the office. You can have a medical assistant or somebody on the team that's part of their job. They're already giving out the intake questionnaire. This is just, you can't make it oh, by the way, we have this research thing we're doing. It's just like part of collecting all the other information that you need and getting the x-ray that you need to take care of that patient.
Yeah, that's a great point. I think one of the highlights for me in the session was Dr. Bozic talking about you wouldn't think twice about investing in revenue cycle management tools or business intelligence, and yet I think there's a big resistance to making an investment to work on collecting some of this outcome data.
I think that's because, again, it has not been required for payment,
right.
and it's not been seen as a tool that can help you competitively in your practice, right. Whereas revenue cycle management is.
Right.
And now that we're moving to an era where we're actually being measured and compared and paid based on outcomes, I think this industry is really about to take off.
Yeah, that's fascinating. One of the other topics that came up multiple times was the idea of the intersection between politics and medicine and eventually policy. And there were some allusions to the fact that the new administration may actually speed or may actually influence the marketplace towards a more competitive situation. Is that something that you agree with?
Well, I think that probably that comment came from me in the session, in that if you look at, first of all, it's important to understand that what government policy is not necessarily what dictates practice and what dictates the trend in healthcare spending and accessibility of healthcare. The government does some things to try to, right now at least, address the growing cost of or increase in healthcare inflation and the ability to provide care to more patients. But if you look at the Affordable Care Act, there are several aspects of the Affordable Care Act. One is an insurance exchange, which is meant to provide more coverage for more patients. The other is innovation around how to get more bang for your buck. That whole innovation piece, a lot of that came from the Republican side of the House and Senate.
Sure.
And so that type of competition that people are hoping to see, that is baked into the Affordable Care Act, I think that will grow and blossom. The basic differences between a Democratic and a Republican administration is the Democratic administration believes that you want more entitlement programs, make not burden the consumer
right.
with the cost,
yep.
and or make care accessible and affordable to patients. On the Republican side, the Republicans want to make care affordable and accessible, but they believe that you can do that through market-based competition,
right.
as opposed through government subsidies and entitlements. And so I think on the market-based competition and value-based competition side, we're going to see an increase in that in the next administration, would be my prediction.
Yeah, that's interesting. We talk a lot about cost because I think it's one of those things that we have grown up with as surgeons and is intuitive because it's captured, the data's there, it's measurable. Administrators have always kind of gravitated towards it. I know recently, it's not a new concept, but you've certainly brought attention to it in the medical field of the idea of time-based or time-driven activity-based costing as a different way to evaluate the cost of a procedure or an episode of care. Can you talk a little bit about that?
Yeah, so as we move into the transition to value, that understanding your costs and understanding your outcomes are critical, as they are in most other industries that compete based on value. And the way that we've historically measured costs in healthcare is through an allocation process, where we say, well, we've got this big building and we've got this many surgeons attending the conference, therefore if we divide that up and,
right.
and assign a certain amount of cost to each physician, then we understand the cost per physician of attending this conference. Well, it turns out that I may be consuming more resources. I'm the one asking for the iced tea. I'm the one going to the gym. I'm going to every session. I'm on the internet. And so unless we're actually measuring what's being used, it's very hard to understand cost. And so when I think about time-driven activity-based costing, I think of it more as a management tool than a finance tool.
Okay.
Where we've used it in our practices to understand what the cost of delivering that 90-day episode of care is, and therefore where the non-value added steps are and where the opportunity is to eliminate waste and inefficiency. So the reason why hospital administrators and many traditional health system CFOs get nervous about it is, well, what happens to all those unattributed costs and who's going to pay for all that? And so I don't like to scare them by saying, okay, we're gonna indirect costs and unattributed costs are somebody else's problem. I'm saying we're using this methodology so that we can understand the actual cost of delivering that care, and then we can use that to refine our processes and improve value. Eventually, hopefully, we'll be sophisticated enough to use it for our finance system so that we can calculate margins and we can use that for gain sharing and other purposes. But right now, we're using it as a management tool to identify where the excess, the inappropriate and excess and non-value added steps in care are.
Interesting. So, in a simplified form, do you think it's a starting place to evaluate cost as implant, length of stay, and you just add those up and then you divide, whatever your outcome gets, or do you think that's too simplistic at this stage?
Well, if you were taking a time to an activity-based costing approach, you would add up the resources that are used, so the amount of physician time, nursing time, anesthetist time, right, physical therapist time, and actually at whatever rate that we understand what that resource costs, and we can calculate what that resource costs per minute, and we can actually measure how much of that resource is being used in the care of that patient. The time that they're sitting down and doing other things that aren't related are, if it's charting or something like that, then that's part of the cost that's attributed to that episode. But if it's doing something else, we don't want to include that in the cost, because then we understand, well, we have a nurse that we're paying for a 12-hour shift and we're getting 4 to 6 hours of direct patient contact out of that. Why is that? Well, maybe we need to make the systems more efficient around them so that they can spend more time in direct patient contact, and that's how it's useful as a management tool.
Yeah, that makes sense. So essentially identifying areas for improvement or to increase the value that aren't currently being utilized, or how to better utilize resources, and kind of tracking the flow of a patient through the episode of care.
Yeah, and understand where you have excess capacity. So if you have a 12-hour nurse that's doing 4 to 6 hours of direct patient care, that's excess capacity that we can apply to something else.
Yeah, fascinating. One more question here while we have Dr. Bozic. It seems like the total joint world and arthroplasty is kind of creeping towards the forefront of value-based care, at least in orthopedics. How do you imagine this movement trickling down, say, into the sports community or the trauma community or the hand community, where you're looking at things that aren't maybe as commoditizable as joint replacement?
Yeah, so good question. The concepts of trying to improve value are ubiquitous and apply to not just healthcare, but everything beyond that. But if you look within healthcare, the easiest place to start is something that you do repetitiously in a relatively homogeneous population, and that's why joint replacement is low-hanging fruit, because we do a high volume and the population is relatively homogeneous, although there's some variability. In those other disciplines, you would simply, the low-hanging fruit and the way to dip your toe in the water and get started is to figure out a condition, preferably not just a procedure, but a condition that you treat commonly, like ACL rupture or hip fracture, and something that you would say, okay, we're going to look at, because the investment in setting up the infrastructure to measure costs and outcomes has to be justified by the volume of patients that you treat with that condition. So if you're doing it for something rare, it's harder to justify that cost, and you're not going to have a large enough sample size to draw meaningful conclusions. So you want to start in a place where you have a high enough volume with relatively homogeneous types of patients, so that you can start to understand your costs and outcomes, use that to improve, and then apply that to other conditions and procedures.
Fantastic. Well, guys, that's Dr. Kevin Bozic, one of the really bright minds in medicine and policy at this point. Thanks for tuning in. We'll have more from AUKUS in the next few hours.
Thank you.